think it's wonderful that you've had such a significant change in your attitude, and I think you have an inner core of strength. But what's come out of this whole experience, I think this is very interesting for everyone, and we're seeing this in different aspects of an oncology, is the role of cardiology and what we call cardio-oncology, which is a completely new area of endeavor. And we're seeing that particularly with just about any potential drug that can cause a cardiac manifestation. We are now really monitoring these people very carefully. So this is really an extremely important area of endeavor. So I think we could do better in prostate, quite frankly, especially with introducing cardiology input very early on.
Just make it a requirement, really.
But it's hard to enforce. As much as I would agree with you, it's very hard to enforce, and there are insurance constraints. But I think
it's probably the first thing I'm going to ask somebody, though, if I wind up talking to somebody who going on to ADT. I'll just say, how's your cardiologist going along with all of this? So, yeah,
you're absolutely right. If you were to meet somebody today for the very first time and they have newly diagnosed prostate cancer, irrespective of the Gleason score, the number of cores, the scans are not done yet, how would you direct them? What would you tell them to do? I mean, a lot of people come in and say, well, we want to meet with this doctor, this doctor, this doctor, and then we'll make a decision. We read this on the internet, we want to see this specific person. So what's your global gestalt? I mean, you've been through the mill now, you've met many different disciplines that were involved in your care. But when someone is newly diagnosed, they really don't know where to go and how to do it. And I think they get a little misguided because Joe Blow next door makes a recommendation, and everybody seems to think that their cancer is the same, when it can be very different in every person.
I really like the idea of another opinion, and I'd like to get an opinion from somebody that is from what I'd call either a magnet system or a hospital of excellence, etc.
So they should go for either to a major comprehensive cancer center or
one one of the upper tier, Mayo, MSK, the Boston one. Sorry, but it bears that because there can be very fine local physicians, but they're not going to have the depth, perhaps, that someone who does that every day and is part of a team of 60 other oncologists, and they're feeding information and so forth. This is one of those things that's such a big moment in your life. And I've had people at work that have, they get diagnosed with breast cancer, and they're working with a very good regional center, and they've got questions, and I'll say, have you considered just going to a major center? Just see if they think that's really the same approach. And if they agree, and they'll say, hey, you know what, you're fine. Your regional center, they've got this thing. And it'll either be a tiebreaker or it'll, make them feel better about the choice that they made.
Should patients see a neurologist, medical oncologist, and radiation oncologist for, quote unquote, the true multidisciplinary approach, or do you think they should go in a step-by-step referral? Because sometimes so much information just floods the system.
Plus you've got people that are in the watchful stage.
That's separate category.
So not going there. So this is somebody who really is going to be moving into an active treatment.
That's exactly right.
Okay. So if they're going to go into active treatment, then I would like to discuss it with the other people, the other specialists, because in my case it was very, very helpful because the thing is, we used radiology. I didn't start with radiology. We almost started with surgery. We went with you in chemical oncology. But the catch is that having the rapport and having already started a relationship with Dr. Zalewski, I found to be helpful. And there he is, part of the team, and so forth. And so when you said, yep, you're going to radiology, then it's like, who's that?
What about clinical trials? I believe that when you and I first met, we were looking toward a clinical trial because we very often will use standard drugs, but in a very novel way. And I believe that because you had the metastases, we couldn't enroll you at that point. But as a patient, does that appeal to you? Because we hear so many misguided statements from patients. Oh, I don't want to be a victim. I don't want to be a guinea pig. And I think people sometimes lose the opportunity to try novel drugs that may really change the biology of their cancer very early on. Were you disappointed when I had to tell you no?
No, because I pretty much trust you implicitly. But, well, you engender that. So sorry about that. But here's the thing. The catch is that if you get someone in a scenario like that, they have an opportunity to go in this. Now, and correct me if I'm wrong, because I don't spend a lot of time doing background research. There's been a change on how these trials are done. And before, there would be a placebo arm, and then there would be an active treatment arm. And then I would see some people that would then, they'd get flipped and you're the specialist in this area, so please correct me. Sometimes the studies would end and the placebo arm would never be treated with an active agent. And then more recently, I'm seeing things where whether it's drug A combination or drug B combination or a placebo and an active agent, there's what I call a humane approach that's been applied, which is as soon as the study has reached some point of findings where, yes, this is the way to go, that sometimes the other arm is flipped active. So I'm just saying, I'm beginning to see that happen. That may allay some of the people's fears that are saying, I'm a guinea pig, I got a 50% chance of getting something that will help me, and if I'm in the other arm, I'm only going to help science.
No, you're actually quite right. I guess in going forward for patients who come in, I think candor is very important, although very often patients do really not want to hear what you have to say, or sometimes people come in and they don't want to change their lifestyle.